Now, first up, unfortunately, the presenter we were due to have, so Associate Professor Jo Atkinson, unfortunately Joanne is sick today, and it's a real shame because it would have been wonderful to have her here to present her work for us today. So Associate Professor Joanne Atkinson is the head of systems modelling, simulation and data science, and the co-director of the Mental Wealth Initiative at the Brain and Mind Centre. But happily, Professor Ian Hickie has agreed to step in and present the work on Joanne Atkinson's behalf. So Professor Ian Hickie is the co-director of the University of Sydney's Brain and Mind Centre. He's an NHMRC Senior Principal Research Fellow, having previously been one of the inaugural NHMRC Australian Fellows. He was also an inaugural Commissioner on Australia's National Mental Health Commission, overseeing enhanced accountability for mental health reform and suicide prevention. He's an internationally renowned researcher in clinical psychiatry with a particular focus on the medical aspects of common mood disorders, depression, bipolar disorder in young people, early intervention and use of new and emerging technologies and suicide prevention. So on behalf of Associate Professor Joanne Atkinson, today Ian's going to tell us about bringing the science of complex systems to population mental health. So take it away, Ian.
Thanks, Claire. And it is a real shame that Jo is unfortunately quite ill today and unable to join us. And as you can see, actually, it'd be much more interesting to have Jo do the presentation. So I will make an attempt to do the voiceover to go with the slides. And some of us obviously have a head for radio. Now, this year, 2020, might well go down in the Macquarie Dictionary as the year for modelling. We've already seen through in this symposium the kind of really important issues of modelling of complex data at the cellular level, the signal level. We've now seen Mac discussing at the whole brain level. A lot of my frustration in the world that I've been in is the extent to which we, in particular mental health, accumulate long lists of risk factors and long lists of what we could do, but we actually operate and live within very complex human systems. And when it comes to informing policy, or actually what we should do, looking forward in the face of complex challenges, and has there ever been a year like 2020, complex challenges like the COVID-20 pandemic, what's to be done may not simply be a matter of listing all of the individual things that could be done or have been done in the past. Joanne Atkinson and her team joined us from the Sachs Institute, very fortunately for us, in late 2019 in association with an NHMRC Centre for Research Excellence that we have on youth suicide prevention. And we were successful in gaining that particular grant because we were able to bring in actually the expertise of Joanne and Adam Skinner and other colleagues, Andrew Page at the University of Western Sydney and elsewhere, in saying in these complex areas, we need to do that. Now, Joanne comes from an issue which I'd like to highlight for all our researchers of actually contract research. She and her colleagues have actually been hired by government agencies to do this kind of work to inform government policy. For those of us who work in academia every day, it's an interesting kind of question. Do you reckon there are people out there who would pay you to actually have the knowledge that you have, that they've got particular questions and you might actually have the expertise or the methods to provide useful answers that would inform public policies, big public policies, every year, every day? We've seen how important that's been in complex modelling of the virus and its transmission this year with regards to other sets of policies. What that's based on is a lot of what Jo's work does at the dynamic level, dynamic system modellings in complex systems. What is the nature of the interaction between various elements? And to what extent can you produce simulations of different scenarios and make predictions that would actually help us to make better decisions going forward, not simply analyse what happened 10 years after it happened. Next slide. So often in the situations where people are having to make decisions, the complexity of the problem, suicide prevention being a classic, societal response to COVID being another. There are many different options that are on the table, most from fairly linear studies between one factor and one outcome. They are actually dynamic. The situation changes. How to contain the virus in Australia in December is not the same as how to contain the virus actually in July. What are we to do in our particular areas in terms of unemployment and social change, its effect on mental health in December this year may not be the same as in March next year, depending on what else happens in the world. The system is constantly changing in its external factors as well as its internal sets of relationships. From an academic point of view, there tends to be everyone who is a specialist and a super specialist in one particular bit offering why I focus on their particular bit might or might not have a certain size effect on the agreed outcome, but is typically done with little reference to the potential that other factors may actually be important. This work really came to my attention and really made me stop and reflect on a lot of my own work, when a lot of issues around suicide prevention was simply being prevented as additive. If we did this plus this plus this plus that, we would get a certain size effect simply by adding up all those things. That never seemed very likely to me. And I must say that Joe and a colleague Andrew Page, in a series of publications we've done together, demonstrated what I was unlikely. It was highly likely that there were negative interactions, in fact, between different factors. That doing one thing may well cause a negative impact on another. And then unless you had some capacity to understand those complex systems, you could actually make bad choices. As we've had the pleasure of telling government during this particular crisis, some of the things that you decided to do may well make things worse. And people go, how could that possibly be? You go, well, actually, once you consider the way that things interact, once you understand a more complex model, it's entirely feasible that that may be the outcome, in which case so-called common sense might deliver an actual harmful outcome. Next slide. So systems modeling really offers a potential to help people who have to make decisions to manage uncertainty, to actually create scenarios. What if we do one thing? What happens if something else happens? What would be the predictions under different sets of conditions? Hopefully to inform planning. You could see, I think, from Kerry Chant yesterday, being in the middle of all those sets of possibilities is not that easy. Yesterday, not knowing where the virus came from, was it locally acquired or not, leads to different sets of decisions. Today, when further information is known, different sets of decisions may need to be revisited. You need a methodology to actually deal with that kind of complex decision making in real time. Next slide. What Joe and her team particularly do is actually create those tools. These are not just academic papers. Not there's anything wrong with academic papers, but they're not one-offs. They create tools that allow people to turn factors off and on in interactive interfaces to look at different scenarios. Where we've been looking at, for example, self-harm hospitalizations in the model they developed with Central Coast, up around Gosford and the Hunter, New England area, you can actually see under different scenarios for different choices, you're likely to get different outcomes in terms of the size of the outcome, the time of onset of the outcome, and in terms of the duration of outcome. And you can simulate investing in different aspects of services capacity, changing other issues in education, changing other areas in terms of other social factors. So you start to produce real-time simulations of what is possible over time. Next slide. Now, how do you develop these models in the first place? Do you just sit in a nice place like my office, very nice office I have here? And I must say, and I forgot to say, on the Gadigal lands of the Eora, on the lands of the Gadigal people of the Eora Nation, I'm very fortunate to sit here, but just sitting here is not a very good simulation for what takes place on the Central Coast where this was formed. One needs to get in the room all of those people and all of those perspectives that are likely to be relevant. So the mathematical models that emerge don't just appear from nowhere. They engage specifically with the stakeholders and others who may have specific sets of knowledge that are relevant to developing the options for intervention, but also holding critical pieces of information about how complex systems operate in that community. Complex systems at the community level, complex systems at the health services level. Next slide. So the process is to get that knowledge, and that expertise comes from many quarters who are actively involved in these fields, to feed it into conceptual maps, to then link it with the research evidence about postulated effects. How big is the effect? How big the effect of any particular intervention might be? What are those domains? And to start to study the potential process of interaction. There's an iterative set of loops here until one develops a plausible model for the factor that you're interested in, whether it's suicidal behavior or psychological distress or the effect of particular interventions. Next slide. Now, you can make models up, but do they mean anything? Well, the first bit of validation is, do they have the capacity to predict what has happened in those areas or with regards to those particular things? If you've got a model that's moderately accurate, it should at least predict the last 5 or 6 years of the behavior in which you're actually interested in. And the models that have been produced by Joanne and Adam and their colleagues have actually reproduced very closely the real-time data. So they do appear to be picking up the factors. I'd like, just as an aside, to mention an occasion when it didn't work and a key insight that was derived. So while doing this work in Western Sydney, it appeared that the models that we had created did not predict the behaviour that had been taking place in Western Sydney over the last 5 years. So we had to go back to the stakeholders and said, look, it's missing something. It doesn't actually work. And they said, you've left out a critical factor, which is the number of people who've been through our various systems in general practice and emergency departments who are now receiving no care in a so-called black hole of serious mental health problems, but not receiving care. Interestingly, once that factor was put back into the model and modelled again as to what that dead end was producing in terms of suicidal behaviour, it did work. So the validation process and the engagement with others is critical, in fact, to understanding what does happen. And the back validation here is the basis on which these models are then formed and then tested and then used to make future predictions about the outcomes in those particular areas in the future. And for the options, those interfaces, to be under the control of local persons who may be in a position to influence the implementation of those particular interventions. Next slide, please. So our work and Joe's work over the last decade, and certainly over the last 5 years in mental health in Western New South Wales, Western Sydney, Hunter and New England, and our most elaborate models on the North Coast, were all being done pre-COVID. And they led to some nasty predictions about what would happen post-COVID if unemployment reaches certain levels and if education is disrupted and if social factors are large. We could see some nasty outcomes during the COVID period. As a consequence of the work we've been doing in local areas, the issue of having a national model to inform national governments was a critical issue, and much debate about what would happen. The backward-looking epidemiologists have tended to say nothing's happened yet, so nothing will happen. We've been saying if you know the factors that are relevant, it's highly likely that things will happen, but if we want to change the outcome, we need to intervene now. And I must say, this work led by Joanne has been so significant to that earlier this year, she gave a presentation at the National Press Club along with Sam Moyston, and the work has been certainly shared with the national government as to what factors may be important. In the wider social world, very much around JobKeeper and JobSeeker and economic support. We've been quite ferocious about education support, but other issues that need to be applied locally, including much enhancement of relevant health systems to support this work. So we have developed a national model because of the national need in the COVID world to actually see what happens next, or to simulate what might happen next. Next slide. So one can develop a core structure for this, and the social structure that we develop very much takes account of the factors that are out there in terms of past developmental histories, employment behaviour, education and training, their relationships with psychological distress, suicidal behaviour, and impacts on mental health services. It's a complex model, but each of the factors has a transparent underlying of what assumptions are being made and what changes can be simulated to see potential interactive effects. Next slide, please. One of the things is testing each of those stocks and flows, each of the captures. Now, obviously, I won't go into the detail here, except to say they are very complex, and you need to look at what evidence exists of likely interactions, plus on the ground, what is the evidence that certain systems are in contact with each other or are influencing each other. And that may change from region to region. Next slide, please. So you can run over time here. What you're seeing is the stocks and flows over time. So it's a dynamic system. It's not simply an on and off system. What you hopefully saw there was actually the ways in which movements in one part of the system are influencing movements in other parts of the system over time. You know, where you have bottlenecks, where you have processes that are feeding back on each other, positive or negatively, over time can be examined. Next slide. For the health services sets of issues, we've been very much focused on what needs to be done in the health services area, including those key factors I was just highlighting, like disengagement from services, treatment not being received, what people perceive to be the need for service, and really important, the extent to which people recover and do not necessarily require ongoing care. Next slide, please. So we look at a whole range of particular services and where they may be operative and what may be the factors within them. Next slide. And we can start to model what will actually happen in these particular issues. Again, looking at factors over time between the model outputs and the historical data that we have for each of those factors in the population or in terms of their use within healthcare settings. The next slide. Then you can put it all together and you can see where it is most opportune to actually intervene. Which bits where would have the biggest effect in the short term and the longer term. Not just say if from one study of one intervention has one size effect size, but what combination of factors is likely to have the biggest effect over what time frame. Next slide. And that complexity basically defeats common analytical tools. Next slide. But what you do end up with are models where you can then simulate what's going to happen. And the critical models we've been working on this year, we do expect, and we have already seen, as has been predicted by our models, significant increases in psychological distress. We've certainly seen in Victoria, where data is available, increased self-harm presentations amongst young people to emergency departments. We have predicted that there may well be change in suicide rates, which, note, largely happened from 2021 onwards. We did not predict that they would necessarily happen this year, therefore the future. But importantly, what governments could do in these various runs labelled in different colours here. What are the best choices to actually prevent as much suicide and mental health harm as possible? And that turns out to be a combination of very important employment and financial supports, plus various increases in certain kinds of health services, particularly assistance to people immediately after attempting suicide, plus increasing deployment of more specialist services. The other one that's my personal favourite, of course, is the use of digital technologies to better coordinate care. Right care, first time, where you live. Next slide. You can actually, if people want to challenge what you've done, you can go and you can put in different simulations. They are transparent models, they're open models for people to actually look at and challenge the assumptions that we've made, or to see whether factors change over time to get larger sets of effects. Next slide. Good. So hopefully that more or less covers what Joe was trying to say. I must say, since we started this work, it's very interesting that government has gone on now and gone out to tender saying we desperately need more of these models. And at a regional level, that is what is happening. It's been a great pleasure to have Joe and her team. We would not have been able to contribute to the public debate in the way we did this year without access to this kind of sophisticated data modeling that is extremely practical in its application. Thanks.
Okay, fantastic. Thank you very much, Ian. I'll just invite anyone to pop their questions in the chat if they have them. We've got a couple at the moment. So Erin Madden has asked, are there any plans to do modelling on how best to implement the recommendations from recent federal reports, for example, the Mental Health Productivity Commission or the ICE inquiry within local LHDs?
Yes, interestingly, the Productivity Commission, despite the millions of dollars spent on it, didn't do it, actually. And we have been in a discussion with government about exactly that at both the PHN level in particular, collectives together, Northern Rivers being the best example, and also at the national level. So that's a very interesting thing. Those who are hired to do it didn't do it. We are doing it.
Thank you. And there's a follow-up question from Erin. Do these models use national minimum data sets for rates of people accessing treatment? And if so, is there any modelling done to estimate who never received care, i.e., not received care and didn't return, but actually never received care?
Yeah, so the didn't come to care, disengaged from care, most importantly, got inadequate care. So they used up the health system, but didn't get a good outcome, a really bad thing that happens in our area. Yes. So estimating the size of that and the effects of those effects in any population. So just a general comment, I've spent the last 25 years of my life trying to increase the access to care, more people in the front end. But if you don't increase the quality of care, you don't improve the outcome.
Okay, thank you. And I guess, yeah, I've just got one last question to finish it off. I was just thinking, I mean, I think as scientists, we're really trained at understanding sort of uncertainty and complexity, and we understand that, models are never going to give you an exact prediction, and that there's a lot of sort of non-linear interactions between the variables and things. But I feel like the general public doesn't have such a good grasp on that sort of thing. So how do you go about kind of conveying the findings or the predictions from these very complex models and sort of making people understand or appreciate what they can tell you and what they can't tell you?
Well, there's two things. You complain about the public not understanding. Many of our academic colleagues hate it. It goes against epidemiology. Oh, no, but I study factor X, childhood sexual abuse, mental health. I don't want to know that there's actually complex. So one of the real resistances is the narrowness of our own particular sets of public policies and activities. We tend to study one thing. And actually, the second bit though is engage in the discussion. So Sebastian Rosenberg's raising the thing, when we were commenting that lifting Medicare sessions to 20 sessions per person might actually, or helplines or awareness campaigns might make the situation worse, people said, how can that possibly be the case? That's more care, that's more something. Something must be better than nothing. So actually engaging in that discussion and then seeing what happens. So in fact, there's good evidence already in Victoria that increasing the number of Medicare sessions covered by psychology to 20 has meant longer waiting lists and less people in care because it's a fixed pie. You know, if you do one thing without the other. So actually being quite upfront with people, but I'd say about a lot of our work, which is complex. We just heard this afternoon, neuroscience ain't simple. But I say to everyone, actually engage in that particular issue. What is the key message? So in this area, just doing something doesn't necessarily help. And what might seem obvious might make it worse. You know, that's what complex systems are about. You know, cane toads, you know, pest control, lots of things, they don't help. In fact, you may create a problem. So I'd really strongly encourage everyone, no matter what the level of science that you're operating in, is to engage in that public dialogue. Because you're quite right, Claire, many of the things that we have to say are complex, but we need to still communicate the implication of our work.